So this section is about diuretic therapy. And we're going to review just the process of the kidneys and how they manage your fluid balance. And so we'll talk about the fluid balance, electrolyte balance, and acid-base balance, and then the endocrine function of renin, erythropoietin, and calcium. So remember, we have our afferent end and the efferent. And in this area here, we have filtration takes place. And then basically we go through the proximal tubule, the loop of Henle, the distal tubule, then the collecting duct. And this is where the renal vein goes. Here, there are capillaries and so on. And so that's the nephron, basically. And when we give diuretics, the indication is usually for hypertension, heart failure, renal failure, liver failure, or pulmonary edema. And the adverse effects are always electrolyte imbalance, dehydration, or hypertension. It's a fine line as we actually assess that. The types of diuretics are loop or high ceiling diuretics, thiazides, potassium-sparing diuretics, osmotic, and carbonic abinase inhibitors. And we often combine two or more of these drugs. So let's just look a little closer at this. So the very first one we look at here are the osmotic diuretics, and they work in this particular area here. And that particular ones are when we're trying to actually pull water into the nephron and increase the excretion of nearly every electrolyte and fluid. So who deserves that? A patient who has a head injury and has increased intracranial pressure, you're going to find that we use osmotic diuretics, and we don't care what they lose. We just want to shrink the brain and before they become brain dead. So you're going to find that this is something that's done, and it's very dramatic, and it just literally shrinks them like a prune. And that is in order to maintain the brain health until they're able to do a bone flap and get the brain freed up, and so that it does not comb into the spinal cord. So that's the osmotic. And then the next one that you're going to find is in the proximal loop here. Basically, this is the absorption of carbonic acid. So that this is for electrolyte imbalances. They would use that particular one there in order to maintain the acid-base balance. Now, this is where the most common electrolytes are used. The ascending loop of Henle is that basically this is your thiazides, and so your the drugs that actually maintain sodium and chloride, but actually excrete potassium. And so hydrochlorothiazide, your thiazide drugs, are the ones that actually work in this particular area. And so these patients are very prone to being hypopotassium and hypokalemia, and that's Ka, anemia. And but your sodium and potassium, sodium and chlorides are good. Even though they are excreted, they come back in again, whereas the potassium does not. So this is the ones that are very commonly used for most in the beginning and early stages. And then we have the distal convoluted tubule. This acts as an early distal tubule, blocks the reabsorption of sodium and chloride in water, and the excretion of potassium is increased. So even more potassium is excreted here. And basically this is, that's a thiazide, sorry. So this is the loop diuretic. This loop diuretic, sorry, is the Lasix. This is where we give Lasix, and this one is where you actually give thiazides, which is the hydrochlorothiazide. And then the potassium-sparing diuretics are over here, and this is where potassium actually is allowed to come back into the kidney. So this is the only one where potassium is not spared, and you don't end up with hypokalemia. So the loop or high ceiling diuretics reduce the sodium, potassium, and chloride, and reabsorption of the loop of Henle is blocked from transporting proteins, and the filtrate becomes hypertonic, drawing more water into the nephron. and able to, you can take it either IV or orally or IM. And the indications are for edema and hypertension. Adverse, of course, is hypotension and hypokalemia. And then the thiazides or thiazide-like diuretics can be given only orally, and indication for hypertension and edema. And then, of course, we have your diureal, which is your chlorothiazide, is an example, and it's for hypertension and heart failure. And the mechanism, of course, is your sodium chloride transporter, and your potassium is left, and less water is reabsorbed. And the prototype is chlorothiazide or diureal. Electrolyte imbalances occur, and serious is blood dyscrasias. Potassium sparing is increasing urine output that promotes retention of potassium. And the mechanism is aldosterone antagonists promote the reabsorption of sodium and secrete potassium. Blocking aldosterone reception prevents that and prevents the reabsorption of sodium, retaining potassium, what happens. And then an example of that is spirulactone or alactone. The therapeutic effect is mild hypertension, and the mechanism of action is to inhibit the action of aldosterone in the distal tubule and collecting duct of the nephron. So sodium chloride and water are excreted, and potassium is retained. Adverse effects are muscle weakness and placidity. So that's a good thing to remember. If your sodium and potassium or sodium and chlorides get down, you have muscle weakness. And if your potassium gets low in the earlier part, when there's low potassium, you have muscle weakness. So electrolyte imbalance in your seniors on your diuretics, muscle weakness is a very common issue. And then this carbon amylase inhibitor, rarely will you see it, but it blocks the carbon anhydrase and the proximal tubule and inhibits the reabsorption of sodium and bicarbonate. And this is the one that prevents the alkalosis and acidosis. It's a weak diuretic effect. It's indicated for congestive heart failure because they become acidotic. And then your osmotic diuretics, I told you, it's for patients who have head injuries, increased indicated pressure. And then, of course, the adverse effects are everything because they've lost all their electrolytes. And they can develop all the things we would avoid with any other diuretic. And so basically you need to do your complete history, vital signs, urine specimens, planning with the family, monitoring electrolytes, monitoring the potassiums, looking for hypersensitivities, and so on.